Well, good afternoon, everyone. My name's John Carmichael. I'm the co-director of the Pituitary Center at USC. I worked for several years at the Pituitary Center at Cedars-Sinai from about 2006 to 2014 when I made the move over to USC. And prior to that was in New York, and that was where I got my start seeing patients with pituitary tumors and working with my mentor at the time, David Kleinberg at NYU. But it's a real pleasure for me to come and speak to you all today. I'm going to be talking about diagnosis of acromegaly. Diagnostic testing is actually why I got into endocrine in the first place. I really like the allure of being able to test something and being so satisfied with getting the answer. And little did I know that things were going to be a lot more complicated than that. And we'll go through why a lot of that is. But you go through your rotations in medical school and residency, and finally you find something that really clicks with you. And endocrine was that for me. So I'll start. I do just one disclosure. I am currently involved in a clinical trial with chiasma, now we'll begin. So, as all of you know, a lot of this is going to be information that everyone is aware of, that acromegaly is a rare chronic disorder. It's got an incidence of about 6 per million. There's a lot of variation in that depending on what study you look at and what numbers you're going through. Diagnosis on average peaks at about 40 to 45. And there's a delay in diagnosis up to about 10 years. And I'm going to stop there and tell a couple of patient stories that exemplify what I think are some of the biggest challenges in making the diagnosis. So in New York, one of my patients had gone through several surgeries. She had had uvuloplasty to correct her sleep apnea. She had had rhinoplasty to correct a deviated nasal septum. She had had realignment of her lower jaw. She had had carpal tunnel release on both of her hands. And that was about 5 years before somebody started to think, maybe this person has acromegaly. And so that typifies some of the things that patients go through where they don't find the right person who thinks about the disease. And when I teach to the second-year medical students, to the interns and residents at USC, and one of the biggest things that I talk to them about is that the recognition of the disease, just the thought of testing somebody, is the key piece in making the diagnosis. It's fairly straightforward, as we'll go through in terms of the testing, but it's that first thought that maybe this patient has acromegaly, and it might be a collection of symptoms. Tragically, it might be a long story of things that have happened to them along the way, but thinking about it early on is key. And I'll tell you another story, and that has another patient that has changed my perspective, and that is a patient who told me once she was diagnosed by her endocrinologist that she lives on a street with about 5 physicians, and there's an annual Christmas party. This one kind of breaks my heart, but she every year would see these physicians over the years, and none of them had said anything to her about having acromegaly. But when she was diagnosed, one of them had sort of the tactlessness of saying, I thought you might have had acromegaly, but I wasn't quite sure. And this has changed my approach. I have been in situations where I've been out in the public, and I know this is a difficult thing to deal with, but I have walked up to people and said, I'm a specialist who deals with a specific disease. I think you might have some of the features, and I'll tell them to talk to their physicians about getting tested. I've had varying degrees of success with that. I've had people who shake their head and sort of ward me off like I'm some kind of demon. I've had, but I have had some success with it, with some patients who, after a long time, eventually come and see me. So sometimes it takes a little while for them to come around. So awareness being one of the key pieces of doing that, and actually saying something and getting to the point where you consider the diagnosis is one of the key things. So just a quick review. I know I don't have to spend too much on this. Growth hormone made by the pituitary, secreted by the pituitary in a pulsatile fashion, and then causing IGF-1 secretion, predominantly circulating IGF-1 coming from the liver, but IGF-1 being a reaction to growth hormone secretion in all tissues. And then when things go wrong, you have elevations of growth hormone, and you still have that pulsatility, but at a very high level usually, and then increases in IGF-1, and all of these coalesce to cause a lot of the metabolic disturbances and a lot of the growth features of acromegaly. So understanding that is key to then figuring out some of the diagnostic challenges and some of the things that we see with patients. This is kind of older data here from Dr. Clemens, and it shows that some of the things, the key features of the disease are very variable in patients. And so, of course, there are the things like the hand enlargement, the foot enlargement that we associate with the disease and what the disease is named after. But we also see sweating in a very high amount of people. Headaches, very common in patients with acromegaly. And then you start getting down through the list, and there are a lot of things here that are less specific to acromegaly. And so you may not recognize that some of these things are the hallmarks of acromegaly. And it does take some recognition of the disease. You know, if the annual incidence of acromegaly is so low, and you look at centers like USC, Oregon Health Sciences University, or some of the busier surgical centers, you know, think about how many of the trainees are exposed to the endocrine care of patients with acromegaly. Right now, the rotation for a resident is a 2-week rotation on the endocrine service. And so the likelihood that that trainee is going to see a patient with acromegaly in the hospital, in the clinic, is very low because they don't have the time to really get that exposure. So important later on in their training to get the exposure to the patients. As I'm sure everyone is also aware, there are several comorbidities, some of the things that happen because of or as part of having acromegaly. And all of these, as we make the diagnosis, then become an important part of evaluating the patient, evaluating the heart for any enlargement of the heart, evaluating the airway for any possibility of sleep apnea, evaluating people in terms of other pituitary dysfunction, evaluating also things like the colon, and Dr. Fleseriu will go through some of the testing that's required after we've made the diagnosis. So testing, as I mentioned, is fairly straightforward once you've thought about it. So once you think about testing somebody for acromegaly, the lucky thing is with acromegaly is that we do have a single blood test that we can send someone to the lab for, and we can have that measured, and we can now, with a little bit more robustness of the reference range and the normal data that we have, we know that if we have an elevation, there are not very many things that cause a false positive of IGF-1. Some of those things might be things that are very obvious, like pregnancy. Some of them might be less obvious, like someone who's later in going through puberty and some of those things that we think about. But at least we have this measurement of IGF-1 that is a very solid screening test for acromegaly. I'll spend some time talking about the pitfalls about the IGF-1 testing, and we'll go through some of the details with that. When we do have a normal IGF-1, in most cases, unless there's some other metabolic disturbance that interferes with production of IGF-1, we've essentially excluded acromegaly. But in many cases, we need a confirmatory test, and that test is the oral glucose tolerance test. It's been around since the late 60s and has been a tried and true method of testing patients for the disease at diagnosis. It's had some variation in terms of testing people after they're treated with surgery, but it is a fairly good test in terms of an augmenting test to the IGF-1 in cases where you have some needs for clarity with the IGF-1. And we'll talk about growth hormone assays as well. One of the things that I did most of my research on has been assay related, and so I am a little too fascinated with how assays work, but we'll go through a lot of this stuff. I think it is interesting to know how these things affect making the diagnosis. So once we have done those tests, then if we've confirmed that they have elevation of IGF-1 or growth hormone or both, then we go on to the pituitary MRI. And lately we have been backing ourselves into the diagnosis with a lot of people being discovered based on MRI findings first, and then IGF-1 measurement or an OGTT afterward. And I think that might be one reason why we're getting a little bit better at the duration of disease. We're seeing people earlier on, we're recognizing earlier symptoms. And I am a strong advocate of checking an IGF-1 for everyone who has an incidental finding of pituitary tumor. If you talk to some of my colleagues at USC who are a generation or two older, this is not something that they would do. They would assess someone clinically. Well, I would argue that early signs are something that may not be as perceptible to everyone, and it's much better for us to screen a very high probability group, such as patients with pituitary incidental findings. So once we've got the pituitary MRI and we've found a mass on the MRI, in almost all circumstances, then we've made the diagnosis of acromegaly from a pituitary tumor, and we go on to then treat the patient with the usual treatment. If we don't find something on the MRI, which happens very, very rarely, then we start thinking about other causes, and we might think about ectopic secretion of growth hormone releasing hormone or ectopic production of growth hormone. And these things are rare, and certainly when you're at this point, the general endocrinologist is probably not well equipped to deal with this. It's very hard to actually find a lab that would measure growth hormone releasing hormone, and so you have to scramble around to try and do a lot of the diagnostic testing. So at that point, if not sooner, my recommendation is that patients who are at that point seek out a tertiary center specializing in acromegaly. All right, so I'm going to transition now to talk a little bit about some of the problems that we've had with assay testing. And as I mentioned, I got into this thinking that testing was so easy. And one of the first examples of this was with the thyroid. And when I was a fellow, I was told, you know what, the thyroid test that you're doing has a lot of issues. You know, doesn't always mean that a normal thyroid level means that someone has normal thyroid function. And so with that bubble burst, I then started looking at all these other examples of when there are issues with assays and with testing. So this is a paper that I cite all the time because of some of the issues with growth hormone and IGF-1. It comes out of the UK. What they did was they sent out a sample of blood to all of the centers in the UK as a quality assessment. And so they periodically do this to make sure that the labs are doing a good job with their measurements of IGF-1 and growth hormone. The clinical scenario was that this was a patient who was being worked up for acromegaly, and they wanted to know what the lowest response after the glucose tolerance test was for the growth hormone, and they wanted to know what the IGF-1 was with a patient who had a pretest probability that was very high, somebody with sweating, somebody with diabetes, and possible acromegaly. So with that clinical scenario, then they got back these results from 23 centers from the IGF-1. And what we see here in the various columns is the same sample being tested with the same assay in the columns, and then at the various centers, if they use different assays, they're in different columns. And so you see here a wide range of variation in the results in the same sample. And we recognized this as clinicians because we were seeing patients with pituitary tumors. We were testing their IGF-1s. We saw values that were bouncing around all the time. We saw a lot of false positives with no recognized problem that would cause an elevation of IGF-1 in those patients, so no pregnancy, no puberty, and still an elevated IGF-1. So we knew that there were some problems with the assay, and this really validated that concern, that there was a 2.5-fold variation in the IGF-1 from the upper result in this study and the lowest result. So really spanning across a wide variation in whether or not somebody has acromegaly and giving you a lot of various results. So this is problematic. Is it answerable? Well, we always tell people to know the assay that you're using, be comfortable with the assay results, and when you get something that doesn't make sense with the clinical scenario, then maybe consider either retesting or figuring out what kind of issues might be interfering with that result. This is also a scenario where you may do the oral glucose tolerance test to back up that result of the IGF-1. The disappointing thing is that growth hormone also had a very high variation in this study. So they sent out this growth hormone sample, 40 or so centers, and 14 different assays used. And these lines that you see across the chart here show all of the different criteria for cure of acromegaly that have been proposed by the acromegaly consensus statements. And you see how these results span from being normal with even the most stringent criteria to being abnormal with some of the older and higher values for the criteria for cure. So again, a very problematic finding. How do we deal with this assay variation? And typically, again, knowing your assay and knowing what to expect from the assays that you use in terms of your own cutoff point and the variation of it. And we'll see a study that really exemplifies that. Here, this study looked at oral glucose tolerance testing in patients who had active acromegaly, in those that were under biochemical control, and then a group of control subjects. And so we see here with the two assays that were used, parallel curves, so they're correlating, but they're not quite giving the same absolute answer. And so knowing that if you were to use one assay versus another, you might get a very different answer, is important in terms of how you make the diagnosis and whether or not you say to somebody, number one, I think you might have the disease or not, or two, I think you might be in remission or not after a surgery. And so important considerations here. And so this then brought about the idea that what we really need is not just a global line, a cutoff point for all patients. We need to, or for all assays, we need to know how the assay that we use in our centers performs and what that normal value ought to be. And so when we see cutoff points of 0.4 or 1.0 or older criteria with older assays of 2 for the growth hormone, what we really need to know is when I send my growth hormone at USC, where does it go, what assay do they use, and what are the expected results? And we need to know studies like this where using Imulite or Nichols or DSL, when a sample is done, what is the highest level that someone with acromegaly would get? What is the highest value that someone who is successfully treated would get? And so this helps us, this is this assay-specific cutoff point that's kind of a holy grail of the treatment of acromegaly. And if we had enough of these studies with all of the assays and enough patients involved with where we could send samples out to all of the assays, then we would have this information for every assay. We don't, and so it's important when you have some special interest in a particular disease, we talk to our labs and we say, look, I know you get a better price when you send your blood samples to this lab, but I need you to send all the growth hormones to this lab, and I need you to send all the IGF-1s to this lab. And so we've done that at USC and have been successful in trying to keep everything all in the same place, because it's tough enough when we have issues with insurance where patients aren't able to come to our own lab. It's tough enough then when the lab then decides, you know what, we can get a better price for this if we just do it somewhere else. So very important to keep it within the same assay. This is one of the first things that I worked on as a fellow, and we were actually looking at patients who did not have acromegaly, but it was eye-opening in the sense that this was the first time that I had seen this degree of variation in IGF-1. This is a study where we asked patients to come in for growth hormone stimulation testing. And during the screening, prior to them getting the test, they signed their informed consent, and then they would get a blood draw as a screening evaluation to make sure that they didn't have a pituitary problem. And so one of the tests that we got was an IGF-1. When we had them come back 2 weeks later for their stimulation test, we redrew an IGF-1 as part of the protocol. And we found that in those 2 weeks, with no intervention whatsoever, no real change in anything, we didn't tell them to go off and do a lot of diet and exercise or many things that can affect IGF-1 when you don't have acromegaly. And we found a wide degree of variation with a lot of patients, up to about, this is 38% on either side here, where there was a variation in their first and second blood test for IGF-1. So again, an eye-opening finding. The testing for IGF-1 has advanced a little bit. We're no longer using that assay. That assay had a lot of promise, but then was discontinued. And now the newest assay, I was part of a study at Cedars-Sinai where we took blood from patients who were seeing us for a wide variety of issues, growth hormone deficiency and acromegaly. We wanted to kind of span a spectrum of IGF-1 results. And we tested their IGF-1s using the current assay that Quest Diagnostics uses and some of the older assays. And we saw a lot of agreement. That's that solid line and how, when it's high with one assay, it's high with another. So there's a lot of agreement. But what we also found was there is a bias. And so we found that a pretty significant amount with the older assays tended to be misclassified or differently classified compared to newer assays. And so this is using now what is their liquid chromatography mass spectrometry assay, which is a very specific way of measuring IGF-1 compared to some of the older immunoassays. And so while I don't know, we never know what the truth is with it. We know that when there's disagreement, there are things that make more sense clinically. But so it does seem to me like the newer assays, we know that on a scientific basis, they're more specific, and it seems like there's a little bit more agreement with our clinical scenario. All right, so getting through all of that then, and finishing up with diagnostic testing, important things not to forget is that we, in addition to the hormonal assessment, we need to evaluate for structural findings as well. If patients haven't had an MRI, they need that MRI of the pituitary and the sella with coronal and sagittal views, with and without contrast, especially at diagnosis, because that helps us to identify normal pituitary and pituitary tumor, and visual field testing. And here you see a patient getting her visual fields tested. This is an example of some of the early findings with the upper quadrants being affected more so than the lower quadrants, but with bitemporal vision deficits because of pressure of a large pituitary tumor on the optic chiasm. And then we do the MRI, and the MRI, of course, is broken down into a wide degree of various categorizations, but the biggest thing that we do is we evaluate for micro and macroadenomas and for invasion. And we do this because macroadenomas and microadenomas have a difference in terms of our initial treatment. So here you see this is a macroadenoma, and this is a patient with suprasellar extension extending up past the, I'm not sure which screen to point at, but I'll pick this one here. How's my aim with my tremor? And so we see extension up through the suprasellar space and compression of the optic chiasm on both the coronal views and the sagittal views. And then here's an example of a microadenoma, something that's well encapsulated within the sella. And so, of course, it just sort of stands to reason that these two examples are going to be different in terms of our surgical results. And we see this in some of the large surgical series. This is one of the largest single series coming out of Germany that shows a pretty significant drop-off rate as soon as there is extension to the sides of the sella. That's that parasellar category. When it's a microadenoma, or when it's still in the sella and hasn't invaded into the other areas, then we see good good cure rates, good remission rates after surgery, 75 and 74% in their hands, but then dropping off to 41% and below with more invasion. So with that, I'm going to turn things over to Dr. Maria Fleseriu, who's coming from Oregon Health Sciences University. She's going to then pick up where I left off and talk about treatment.
Thank you so much. And we'll do questions in the end. Thank you so much for the invitation, Jill. I know you invited us first at Chicago, but I had to drop my kid to college. I'm sorry. So that tells you about my age also. And it's a pleasure to be here. Can you put the next set of slides, please? To see all of you so much involved in talking about acromegaly, and tomorrow in meeting with all our colleagues at the Pituitary Society. I'm president-elect of the Pituitary Society, so starting July, I'm going to work even closer with some of you. I'm also a professor of endocrinology and neurological surgery and director of the Pituitary Center at Oregon Health Sciences University. And you know, we usually say this is the latest set of presentations, but I can guarantee you that's the latest of the latest because I did the slides last night. So more recent than that, you can get it. And I also included a paper that we published in Endocrine Reviews about complications. It's about 80 pages. I didn't ask you to read it by now, but we can definitely talk about it. So these are my disclosures, and I receive research support from Chiasma, Ioannis, Novartis, and Pfizer to OHSU as principal investigator and scientific consulting fee. We're going to do studies with Crinetics, but we didn't sign the contract yet, and I'm receiving scientific consulting fee from Ipsen and Ono, and also soon from Crinetics when the contracts will go through. So talking about comorbidities, what happens with acromegaly? Each of you have your own story. So you know exactly how late you were diagnosed. You know way better than us how hard it was to convince many, many doctors that something is wrong with you. So we know that because when the patients are coming to us in a pituitary center, we know that the mean delay in diagnosis, as you heard earlier, it's up to 11 years. It's not changing too much, and you can see some of the posters that we looked at our data at OHSU, and it changes a little bit, and we're doing much better with screening. And at our institutions, when I moved there, we changed the curriculum for medical school, so every other year it's a patient with acromegaly that meets with a medical student, so maybe they will remember and they won't forget once they see a case. And that we're making a little bit of strides, but as all of you are aware, this is very hard because IGF-1, it's a complicated assay, and overall, it's a rare disease. It doesn't change your personal experience. But if we're looking at what happens because of most likely the delay of diagnosis, is that this was the largest that we have right now of a French registry, and it's almost 1,000 patients, as you can see. And I'm looking to see, but it doesn't show here. Okay. Huh. You're actually good. I almost wanted to make fun of you, but I can't do it. And my knee is not working well, so I think I'm going to tell you by colors. Do you have something that I can use on this one and then translate on the other screens, or no? US, as you know, and we're working towards that, but it's going to be a much more complicated. And 30% of patients will have pituitary deficiency. So why? It's not acromegaly per se, it's just that the tumor because of the delay of diagnosis. So you'll see a lot of these things, complications-wise, might be improved if we'll have an earlier diagnosis. So sleep apnea. Sleep apnea is very frequent, and I'm sure several of you know, but when we're seeing patients that are coming to us as second opinion, a lot of them did not have the sleep studies done because nobody talked to them about the sleep study per se, because of course the tumor was more important, vision loss is important. But there are several things that we can fix in order to improve the comorbidities. And it's true, the symptoms are not very specific. Daytime sleepiness and fatigue, I probably have some of these symptoms right now. So it's very important for you, not just to know which are the things that you have to advocate for yourself, but which one are the main complications. And furthermore, I don't want to go into too many details how to screen it, but it's very important that even if you have a diagnosis of sleep apnea and you are already on CPAP with changes in control of the acromegaly, the settings need to change. And furthermore, a lot of the patients think, and some of the doctors too, and we used to think that too before we did the studies, that if you control the acromegaly, then the sleep apnea is going to go away, and all this is due because of the enlargement of several of the organs, including larynx and tongue. So I have here a picture of, this was published also by a French group, and as you can see, this is the back of the tongue. I'm going to show you here, sorry. And this is after treatment. So you can see clear improvement. So we thought for years and years and years that this is the cause of sleep apnea. Guess what? 30% of patients have central effects. So the high growth hormone has direct effects on the brain. So just fixing and not snoring might not be enough. So it's very important to do testing, and we recommend everybody a diagnosis at least. And if you didn't have it, ask your primary care doctor, because some of you that you are not from US, you know that the insurance requires a referral, and the referral has to come most of the time from a primary care doctor, regardless what the guidelines are saying. And then the insurance comes back and asks, why does the patient need a sleep study? And then we'll go back. So how about other comorbidities? So this is one of the most frequent one, and it's also interesting being peripheral, but also central. So remember that. Heart disease. That's even more complicated. It seems to be, but I have some good news too, so I don't just come with bad news for you. Things are improving significantly. So the only thing that we didn't make any changes is the delay in diagnosis, unfortunately, for most of you, was years and years in the making. But for complications, especially for cardiovascular disease, the last paper that we looked at all the data, the cardiovascular complications have improved significantly. Of course, we have a lot of medications and we know more about it. But what happens with the growth hormone? You know that everything is enlarging, you know better than us, but also the heart muscles are enlarging and also getting thicker. So this comes with valvular disease and also high blood pressure. High blood pressure is multifactorial. You can have it without growth hormone excess, but it's very important to control both of them. So we usually recommend an echo, a diagnosis. The guidelines are saying the same thing. Again, we go back to the insurance, and the insurance says, why does the patient need an echocardiogram? Because that's not an approved diagnosis. I strongly recommend all of you to discuss with your providers. You'll never know what you will find. It's possible to be normal. We looked at the reversibility of changes, and sometimes with extreme high growth hormone, the things are improving, but it's very important to know, because what are we trying to treat? Yes, we're doctors, we're endocrinologists. As John said, we're all, we love acromegaly, and we also love endocrinology because it's numbers, but numbers are not enough. So we know that treatment prevents disease progression and also cardiovascular disease. And especially if you're on medications for acromegaly, don't forget about other medications, especially for blood pressure. That's very important. And sometimes if we find things in echo, I always order the echo. And then if I see something that I don't know, because a lot of things I don't know, then I send the patient to a cardiologist at least to have an evaluation back and see what it means. Furthermore, we found a lot of patients talking about things that I don't know, with aortic root extension. So it's clearly there are some other complications that we can find, and looking back, that's probably also related to growth hormone, though it could be a coincidence in itself. How about diabetes? That's very hard because there are a lot of other risk factors that are not related to growth hormone that are related to insulin resistance. So diabetes and hyperlipidemia, it's very hard to say. If the patients are asking me what's causing it, is the growth hormone? I say definitely it plays a role. Is just the growth hormone? We can say that. So it's less defined than it's, for example, for the blood pressure, that we know that the growth hormone has direct effects even at the kidney level and sodium handling, so it's way more clear that, and sometimes it's even easier to improve. For diabetes, it's much more complicated than that. There are direct effects, though, of the growth hormone with insulin resistance on fat storage, muscle and fat tissues, and liver overproduced glucose also. What we should do for all the patients that have acromegaly, and that's not very clear, and again, if the patients are on Medicare, sometimes I can't even check an A1C, but we strongly recommend the fasting plasma glucose, hemoglobin A1C, and the fasting lipid panel. Could not be related to acromegaly, but we need to know because we want to treat and improve. Now, talking about more complicated things, once we find it, that might change the decision of which type of medical treatment we're going to prescribe. It's not changing significantly because I look more at resistance versus to control the growth hormone first, but this might be important overall. So if we're looking, this is the latest paper that we try to combine all the effects of all the medications, so I don't want you to remember all the details of it, but I wanted you to remember that the status of the glucose is important because some medications might improve glucose control, some make it worse. And again, it's a decision factor, and we're going to talk about each therapy, because if a tumor is very large, we think about the tumor and forget about the diabetes for a short period of time. But overall, I want each of you to know that the physicians are looking at you as a whole, or at least they should, and all of this has to be put in perspective. How about colonic polyps? You heard a little bit earlier, and we're going back and forth at each of the consensus meetings and with all the data. Is the risk of colonic cancer increased in acromegaly or not? Keep in mind, the title of this is colonic polyps. So colonic polyps, that's not cancer, it's clearly increased by growth hormone. So we know that. That's a set. Now, colonic cancer, in all the data, and I showed you the data from France and some other studies, yes, it's increasing. Do we know for sure that this is due to the growth hormone? No, because we recommend colonoscopy, and I'm going to tell you in the next slide that I want all of you to do a colonoscopy at diagnosis, and then after that. So of course, if you do a colonoscopy, you find more colonic polyps. Just by chance, some of these would be colon cancer, and hopefully a smaller one that would be removed. The only thing that I want you to remember out of that is not to think that you have an increased risk of cancer at the colon level, but what you need to remember is you need a colonoscopy. And if you have colonic polyps, that's essential. The risk of having uncontrolled and worsening prognosis of the cancer is clearly related to the level of growth hormone. So that's very important, and that's why sometimes we're aiming of more control of acromegaly if this is the case. How about bone disease? We knew that the bone is affected in acromegaly, but we thought for years and years that it does not change too much because the growth hormone is building bone. It's building bone, but now we know it's building bad bone. So the risk of small vertebral fractures, if we're looking at X-rays, and again, it's not, we're not trying to promote our research, but we can, if you're going tomorrow, you can see the prevalence of vertebral fracture if you do X-rays is very, very high. Now, if they are small, we can't do too much because the treatment for this would be much more complicated than the disease itself. But if they are associated with also decreased bone density, that really shows a need for treatment of the bone, and sometimes with bone density. If your doctor is doing a bone density and tells you that's it, that's not good enough, because you can have normal bone density that's falsely elevated overall. And I'm showing you some X-rays with several vertebral fractures in a patient with acromegaly and no other diseases overall. How about thyroid nodules? The same thing. If we end up doing thyroid ultrasound, we are going to find a lot of thyroid nodules. That's happening in normal population too. So the recommendations are, because that's not as severe as the colonic polyps that we really like to know if you have it or not, are, if we palpate a nodule, we'll do an ultrasound. If we don't palpate a nodule, we don't want to do an ultrasound. The same thing as in normal population. I don't want to know how many nodules I have, because then I will need a biopsy, and then something will be there and doesn't mean anything. So that's where we recommend not to do any testing for that. Of course, we test the function, but not to look for nodules itself. And before we move to treatment, that I'm going to briefly review each of them, I want to put in perspective everything that I told you. So there are a lot of complications that we're looking at the growth hormone from physician point of view that you are describing to us, and we find it. So this is it changing. It's impairing the physical functioning overall. You heard about pain earlier. I didn't hear what you were told, but I hear every day from patients. We have over 200 of patients with acromegaly. And then the depression and anxiety that's due to the disease itself, and then we're not helping with treatment either. We show that even the cognitive function itself is related to growth hormone. And then everything that we put on you, the burden of chronic medications, we did not come with much better one. The radiation has severe significant side effects, and I'm not going to talk to you about too much. And of course, the hypopituitarism overall. So the treatment is evolving. So if you're looking at your doctor and say, why are you changing on me all the time? This is because the cutoffs are changing, and the reason is that if you're looking here, I promise you I won't have too many graphs, though I can stay away from graphs, is that data on mortality and also comorbidities is related to the growth hormone. So several years ago, it was good enough to have a growth hormone of 5. Now we know that at 5, that's way too high, and the growth hormone should be around 1. So this is related based on populational data, and this is data from New Zealand that clearly shows probably different assays we can translate directly, but lower growth hormone, not in the area of growth hormone deficiency, but would be important to have it normal. Treatment goals. What we're trying to achieve, so you know why we're pumping up so many medications, are to reverse the clinical signs and symptoms. Some we can do it, but we try. Preserving the pituitary function, so that's why we're using radiation third line. To control the numbers, you heard we're number people, both GH and IGF-1 for most of the medications, and then to preserve and make sure that the tumors are not growing. How do we achieve that? We're trying to look also at patient-reported outcomes. So what I showed you earlier is we really want to have normal numbers, but we're interested in, and I'm going to show you a little bit of data about, and some of you have been participating in the studies, what's happening from your point of view with what we're trying to achieve. So at least, and you'll hear more tomorrow from the FDA, the patient-reported outcomes are becoming very important, and the more we're looking at it, we realize that we should have done this a little bit earlier than that. So these are the latest set of guidelines, and you are all aware that they exist. I don't want you to look at every line, but that's why we're teaching other doctors to look both at numbers, and there are several options, and not just to start a medication and then not check anything for a year and go from there. Everything should be in flux, and yes, of course, we need both GH and IGF-1 unless the patient is on pegvisomant, and ideally to use the same assay, and you heard why it's so important. The problem is the labs are changing assays on us regardless. So what are the reasons for uncontrolled acromegaly? So if we're looking, and I'm showing this to the doctors, that this was a small study done in Germany, almost 60 patients. This was reported by treating physicians. And look that they said that 20 patients out of 50, so that's 10%, patients denied therapy. So I'm sure the patient denied therapy because nobody explained them exactly why they need to take therapy. And then non-compliance is probably the same thing. If it's a very complicated treatment and the patient doesn't really know exactly what they are taking, well, I wouldn't like to take something that I don't understand why should I take it. So what are the groups? So we're not talking about the new therapy. I will have a slide at the end with everything that's coming new, and you can hear more later. But these are the drugs that we have right now available. So we have drugs that are working at the pituitary level to decrease the growth hormone, and subsequently the IGF-1 in the liver is getting smaller. And then we have pegvisomant that works in just blocking the receptor, so the growth hormone stays the same, the tumor is there, but the effects of the high growth hormone will actually be negated by that. Now, this slide shows you just, I want you to look just what's in red, is that the two medications that we have between octreotide and lorotide are relatively similar. And if we're looking at all comers, work in about 50% of patients. And this was a study that John did and looked at meta-analysis of a lot of other studies with a lot of caveats of studying, including, I'm not saying he didn't do a good job, but keep in mind, it's about 50%, so you need to know. So you need to talk to your doctor and say, I know that it's going to work in probably 50% of cases. What's my next step? What else do I need to do? And furthermore, there are a lot of predictive factors. So we know this is a study, this was an observational study done for lanreotide. The data should be similar with octreotide too because they're relatively similar, that if you're looking at classified by BMI, so talking about weight, and you can see here, I'm really sorry I can't move there, but my knee doesn't let me move so fast, I'm sorry. You looked at the patients with higher BMI needed higher doses. So it doesn't mean that if you have higher BMI, the drug is not going to work, but the doses need to be adjusted. So these are, on purpose, I let the same slide that I'm showing to the physicians, but I put in yellow what I want you to focus. So one, to give some slack to the physicians that they have to go through a lot of things to know why the drug is working or not working. But in yellow, there are some things that are important, and a lot of centers are not even looking at that, and they're just starting the first drug that comes across. And for some patients, we know it's less likely to work. So there are right now, if we're looking for receptors, might make a difference. We're routinely looking for receptors in the tumor, for example. The type of tumor, sparsely granulated or densely granulated, that should be done. And I'm seeing now at least half of the patients that have surgery somewhere else and they're coming to us for another opinion. I'm redoing the pathology at the first visit because we don't have the data, and it's essential for me if they're not in remission. And now we have more data that how the MRI looks like might also change how we're going to approach the patients. This was a study that we did now many, many years ago for the type of tumor. So if the patients, if we looked at the type of tumor they had and we treated them with medication, it's the likelihood of responding was completely different on what type of tumor they had. So that's a very important information. Now, we're still at octreotide and lorotide, first generation of injectable medication. So talking about, this has not been published, so I can show you more than that, but we presented the data as an oral now several months ago. So this was in the initial screening study. And when the patients, some of you probably were part of it, were asked about symptoms on the injectable medication, as you can see overall, there was a lot of satisfaction with the overall treatment, but still 34% of patients reported problems with treatment, and then 23% were bothered with scheduled injections, and half of them, I'm amazed that it wasn't more than that, were really bothered by the fact that they have to travel for injections all the time. So we need your feedback. For some things, as I showed you earlier, they're not changeable. So it depends on the type of tumor, what treatment we're going to use. But then we probably, based on patient-reported outcome, we can change some of the things. The same thing with comorbidities. The cartilages that are damaged, nobody's going to be able to fix it. If I would know that, I would fix mine without surgery, but it's impossible. But for example, we know that if we control the growth hormone, we can prevent further damages of the cartilages, for example. Paclitaxel is a new multi-ligand somatostatin receptor. You probably heard about it. In Europe, it's used as second line. In US, we're using sometimes first line for tumors that are really large, and we know they're not going to be responsive, so mostly for tumor effect. The response rates are better than with octreotide or lanreotide in about a quarter of patients with significantly more hyperglycemia. So we go back with what I told you earlier. If we're looking at tumor and we need to fix it and 2 surgeries didn't work, then it's a different story. But the diabetes, we know how to treat it easier. If it's a patient has no other comorbidities and smaller tumors, then diabetes might become important and we use other treatment. And these are the rates of hyperglycemia that we sometimes can see. Changing to other type of treatments, I said earlier that we have the growth hormone receptor blocker, pegvisomant. This is, and again, for this on purpose, so most of the slides I changed from what I showed to the doctors for you. This I left it on purpose, again, the same, to show you that you have to be aware that just taking a drug is not enough. This was a large observational study of patients that were on pegvisomant around the world, so this is not just US doing not a good job. And on the left, you have the patients that normalize IGF-1, and on the right, you have the patients that didn't normalize the IGF-1. And here you have the doses that the patients are on, and as you can see, was almost no difference. And this is a drug that we know that ramping the dose, like in other drugs too, might change outcomes. So being on a medication is not enough. You have to make sure you're on the right dose also. Talking about focus on yellow. There are a lot of factors that some are more complicated and a lot of them are research level. But I want you to look at what's in yellow that might change the doses that you need. So if the patient doesn't have diabetes, the dose that's needed is clearly less. So if the patient has low IGF-1 at baseline, the dose is less. So we shouldn't start higher dose where you can have more adverse effects and then cut back, going the opposite. Sometimes when I want to control a patient because it's severe disease, I'm starting very high and then cut back, but this is depending on the patient. About radiation, I don't know if Garni showed you more because, sorry, we're in pituitary meeting, we didn't come earlier, but radiation is third line. So for acromegaly right now, we should not use radiation immediately after surgery. We have many medications, and radiation has complications in itself. Sometimes we need it, and we recommend if the tumor is growing, if it's more aggressive, but we should look at particular cases per se. There are several new drugs in development, and some are in more advanced cases and trials, and some are phase 1 and moving along. I'm not showing you all of them. What I show you here are the ones that are phase 2 in progress or phase 3. So the oral octreotide, you have a paper that's already published as phase 3. It's one that's still in progress and one that ended enrollment, but we don't have the data yet. For octreotide depot, it's a phase 2 that was done in Europe, both for acromegaly and neuroendocrine tumor, is probably going to move to US. The somatoprim, it's a newer type of somatostatin receptor ligand that's phase 2. And then the kinetics studies, there are 2 phase 2 studies with different inclusion criteria that are in progress. You can find on clinicaltrials.gov. And also an antisense therapy from Ionis, that's the phase 2, is in progress in many centers in US. Both kinetics and Ionis are also done in US. And I would be happy to answer questions if you need it. So what are we looking for a therapy for acromegaly from a physician point of view? In the ideal world, this is ideal. We want the drugs to work. We want to be safe and well tolerated. We want the patients to stay on treatment. And then, of course, we'd like to be cost effective, but we're not going to talk about that because we don't have 2 days to discuss it and then no results whatsoever. This is how this used to be the old one. How everything, the patient satisfaction was not even included, but in the recent papers, do you see it's in yellow? That's why. Because it's new, and this should be the focus. So In the same time, we cannot think just about that unless we're talking about being an efficacious treatment in the same time. Because we want the treatment to work, because that's our job as physician. So I will never prescribe to a patient a drug just because that patient would like it, unless I know for sure it's going to work. How to monitor? You heard that it's really hard to do different assays. When to follow? All of us are having different intervals time. Complications, both screening and management. And then I didn't show you the data, but it's mostly outside US, because in US we have no data, that a lot of patients are lost to follow-up, and mostly because what you were saying earlier, that you're fed up with physicians at some point and not discuss enough, and then some patients are not going back to follow-up. So there are studies in Brazil and in Europe, and I'm sure in US too. Over the years, we change, and this is how we're trying to teach the other physicians, but our main job is, in the same time with listening to the patient, to make sure that we're treating all the comorbidities and make sure that all the screening is done and use the best treatment possible that will achieve both efficacious treatment and patient satisfaction in the same time. So if you want, I can make that much larger, but it's not going to change my practice, because my goal is a satisfied patient, that I'm listening from patient-reported outcome, but normal labs in the same time. So we'll do good. No, so no, I'm almost done, and then we have to go back to the pituitary meeting. But I want John to be able to answer some questions too. So in general, we're trying to find the best treatment, and which patient will be the best for each type of treatment is going to be dependent on a lot of individual clinical attributes, and each of you is different. Some patients might prefer something, some patients might prefer something else. Oral versus injection, repeat surgery. I have patients, not just for acromegaly, for Cushing's too, that every 10 years want to go to surgery. Then you go to surgery and the surgery doesn't work and you're back on meds, so the patient comes back and says, why you didn't tell me? Sorry, I know, surgery works, but not always. Why you didn't tell me that the chance is worse, or what the other doctors didn't tell me that the chances are half. So we're trying out of all these different colors to find the right treatment for the right patient to achieve everything we talked earlier. So in conclusion, normalizing GH and IGF-1 reduce morbidity and mortality to expected level. We want to have, and I'm sorry it's not in bigger characters, but we want the patients to have significant quality, better quality of life, so that's our goal after the numbers. Patients' reported outcome need to be incorporated in therapy evaluation. Treatment should be individualized depending on the patient. I didn't show you the data, but we're using a lot of combination therapy after the European model, and cost-effective personalized approach to precision therapy should be the future. This is gorgeous, sunny Portland, Oregon, and it's a pleasure to be here. Thank you. John?